Welcome to the deep dive. We're doing things a bit differently today, a real laser focus. If you're getting ready for your emergency first aid at work practical course, especially with Paul and Kenny training.
Yeah, the hands-on session.
Exactly. And maybe you took a similar course, say, 3 years ago. Well, this is for you.
Because things have changed, haven't they, the 2022 updates?
They have. So we've gone through the EFOL 11th edition handbook and that key document about the 2022 workplace unit changes.
Right.
Our mission, basically, is to give you a fun, effective study guide hitting all those practical points you'll be assessed on.
So you feel totally prepared. Yep. Think of it as your audio cheat sheet, getting you up to speed quickly.
We're covering, let's see, DRABCD, CPR, how to use an AED.
Recovery position, breathing checks, seizures, choking too.
Oh, yeah, and external bleeding and that hypovolemic shock thing.
Exactly.
Yeah.
It's your warm-up before you get hands-on with Paul.
Okay, let's dive straight in then. The absolute foundation. DRABCD. But wait, before even that, the scene survey.
Crucial first step. Absolutely. The handbook really bangs the drum on this one. CLAP. Control, look, assess, protect, or prioritize.
CLAP. I like that. So control. What does that mean exactly?
Well, it's about managing the situation, looking for potential hazards, anything dangerous around.
Right. Check the water before you dive in, sort of thing.
Precisely. Is it safe for you? For bystanders? For the casualty themselves? You're no good if you become casualty number 2.
Okay, safety first. Got it. So scene's safe-ish. What's next?
Then we get into the primary survey proper, the DRABCD. Danger, response, airway, breathing, circulation, defibrillation.
We've kind of covered D for danger at the scene check.
Yep, nailed that.
Yeah.
So moving on to our response, how do we check if, they're conscious?
How do we see if anyone's home?
Basically, yeah. Both the handbook and the update mention using the AVPU scale.
AVP.
Alert, voice, pain, unresponsive. It's like a quick check. Are they awake? Eyes open. That's alert.
Okay.
Do they react when you talk to them? That's voice.
Like, hello, can you hear me?
Exactly. If nothing, then pain. A gentle stimulus, like a squeeze on the shoulder. See if they react.
And if still nothing?
Then they're unresponsive. Simple as that. Oh, and a good tip from the guide. Approach from the feet if they are responsive.
From the feet? Why is that?
Helps avoid them jerking their head back suddenly if they have a potential neck injury. Just a precaution.
Makes sense. So, hello, are you all right? Gentle shake, nothing. Okay, they're unresponsive. Next is A, airway.
Right. We need to make sure the path for air is clear. The standard way is the head tilt chin lift.
How do we do that again?
You put one hand on their forehead, gently tilt the head back, then use the fingertips of your other hand under the point of their chin and lift it up.
Ah, okay. So forehead down, chin up, lifts the tongue away.
Exactly. Lifts the tongue from the back of the throat, opens the airway right up.
Simple but vital. Okay, airways open. Next is B, breathing.
Now this is a big one. Look, listen, and feel. But only for about 10 seconds max.
10 seconds. And we're looking for normal breathing, right? This is where those 2022 updates really come in, isn't it? Agonal gasps.
Yes, that's a really critical distinction. The handbook points out that sometimes, right after the heart stops, someone might take these weird, infrequent, gasping breaths. They sound awful.
Like fish out of water.
Kind of, yeah. They're not effective breaths. They're not getting oxygen in properly. They're called agonal gasps.
So how do we tell the difference?
The key takeaway from the update is, if you have any doubt whether the breathing is normal, just act as if it's not. Assume the worst and get ready for CPR.
Better safe than sorry.
Absolutely. So look for the chest rising and falling regularly. Listen close to their mouths for normal breath sounds. Feel for air on your cheek if it's not regular, if it sounds like gasping, or if you're just not sure.
Act. Start CPR. But what if they're breathing normally but still unresponsive?
Good question. If they're unresponsive but breathing normally, that's when we think about a secondary survey, checking for other injuries and getting them into the recovery position, which we'll cover. And crucially, calling for help.
Right. C for call 999 or 112, or circulation, depending on the version. But the call is vital.
The call is vital. The guidance says, ideally, get someone else to call. A bystander, point at them, tell them, call 999-112 now.
So you could stay with the casualty.
Exactly. If you're alone, use your mobile on speakerphone if you can. Keep it beside you. But if they're not breathing normally and you're alone...
Start CPR first.
Yes. The priority shifts. Compressions are key immediately. Call after a minute or so, or use speakerphone if possible. And don't forget the AED. If one's nearby, send someone for it. You go get the defibrillator.
Which brings us nicely to D, defibrillation.
Yep. If that AED arrives, you switch it on straight away and just follow the voice prompts. It talks you through it. It works alongside CPR. We'll dig into AEDs more in a sec.
Okay, wow. That's DRABCD. A lot packed in there, but it flows logically.
It does. Scene safety, check response, open airway, check breathing, call for help, and get the defib. That's the core sequence.
Right. Let's move on to CPR then.
Yeah.
Cardiopulmonary resuscitation. The handbook says it's chest compressions and rescue breaths.
That's the standard approach, yeah. Compressions pump the blood around manually, and the breaths get some oxygen in, keep things going until help arrives or the heart restarts.
So adult CPR, hand placement, where exactly?
Center of the chest, heel of one hand right in the middle. Imagine a line between the nipples, put the heel of your other hand on top.
And interlock the fingers.
Yep, interlock fingers and keep them off the chest. Helps focus the pressure through the heels of your hands, then get right over the casualty, arms straight, shoulders above your hand.
Use your body weight, not just your arms.
Exactly. Lock your elbows. Push hard and fast.
How hard and how fast? That's always the tricky bit to judge.
The depth is about 5 to 6 centimeters for an adult. Think the height of a credit card on its edge, roughly.
Okay, that's quite deep.
It is. And the rate is 100 to 120 compressions per minute. Fast. You know the song, Staying Alive?
Huh, yeah, everyone mentions that one.
It's got the right beat. Helps keep the rhythm. You do 30 compressions.
30 compressions, then 2 rescue breaths.
Right.
How do we make sure those breaths are, effective?
Good question. You need to maintain that head tilt chin lift to keep the airway open, pinch their nose closed, make a good seal over their mouth with yours. Breathe steadily into their mouth for about 1 second.
Just 1 second?
Yep. Enough to make the chest visibly rise. Watch for it. Then take your mouth away, let the chest fall, take another breath yourself, and give the second rescue breath. Again, watch the chest rise.
And the whole thing, both breaths shouldn't take long.
No more than 10 seconds total for both breaths. Minimize interruption to compressions. If the chest doesn't rise on the first try,
check the airway again. Retilt the head.
Exactly. Check the seal. Don't try more than 2 breaths before going straight back to compressions. 30 compressions, 2 breaths. Keep going.
It sounds exhausting. How long to keep it up?
Until proper medical help arrives and tells you to stop. Or until you're physically exhausted and literally cannot continue.
Okay.
Or if the casualty shows definite signs of life, starts moving, opens their eyes, starts breathing normally. Or if an AED prompts you to stop, perhaps for analysis or a shock.
Right. And if someone else is there?
Swap. Definitely swap rescuers every, say, 1 to 2 minutes. The handbook stresses this. Quality of compressions drops off quickly when you get tired. Fresh arms maintain the depth and rate.
What about compression-only CPR? I've heard about that.
Yes, the handbook covers it. If you haven't been trained in rescue breath or you're unwilling or unable to do them for whatever reason.
I'll do the compressions.
Just do the compressions, continuous chest compressions, same place, same depth, same rate, 100 to 120 per minute. Don't stop. It's way better than doing nothing. Still circulates blood.
Good to know.
Yeah.
Now, we're focused on adults for this EFAFW course, but the handbook mentions infants and children briefly. Any key differences worth just sort of noting?
Just for awareness, really. An infant is under 1 year. A child is 1 up to about 18. For them, especially infants, you check response more gently.
Okay.
And a big difference for kids and babies, you actually start with 5 initial rescue breaths before you start compressions because their problems are more often breathing related initially.
5 breaths first. Got it.
And the compression technique is adapted. 2 fingers for an infant, maybe 1 hand for a small child. But yeah, like you said, the assessment focus is adults.
Right. Okay, let's talk AEDs. Automated external defibrillators. The potential lifesaver. How does it fit in with CPR?
It's built right into the process. The handbook says if you don't have an AED right away, start CTR. As soon as it arrives, get it switched on.
Okay.
If there are 2 rescuers, one keeps doing CPR while the other gets the AED ready and applies the pads. If you're alone, you have to stop CPR briefly to switch it on and attach the pads.
And then the machine takes over. Tells you what to do.
Pretty much, yes. It gives clear voice prompts, sometimes visual ones too. The main thing you need to do is get those pads on correctly.
Bare chest, right?
Bare, dry chest. Follow the pictures on the pads for placement. Usually one below the right collarbone, the other on the left side, below the armpit.
What about things like pacemakers or piercings?
Good point. Avoid placing pads directly on them. Put the pads slightly to the side. Same for medication patches. Peel them off first. And quickly wipe the chest dry if it's wet.
Okay, pads are on. It starts analyzing. What's the absolute must-do then?
Stand clear. Nobody touches the casualty during analysis. The AED is reading the heart's rhythm, any movement interferes, and definitely no touching if a shock is advised.
Right, safety for everyone else. So if it says shock advised,
it will charge up, then it'll tell everyone again to stand clear. If it's semi-automatic, you'll need to press the flashing shock button when prompted. If it's fully automatic, it'll give a warning and deliver the shock itself.
okay, and after the shock, or if it says no shock advised.
Immediately resume CPR. Straight back onto the chest, 30 compressions, 2 breaths. The AED will usually tell you to continue CPR. It might reanalyze after 2 minutes. Just keep following its prompts.
Keep going until.
Same reasons as before. Paramedics arrive, casualty wakes up, you're exhausted. Oh, and if the person does start breathing normally and you put them in the recovery position later,
Leave the pads on.
leave the pads on, just in case they deteriorate again. The ambulance crew will want them there anyway.
Makes sense. Okay, that covers CPR and AEDs well. Let's shift to the recovery position. When do we use this?
Okay, so this is for someone who is unresponsive. You've checked AVPU, they're you, but they're breathing normally. You've done your look, listen, feel, and breathing is definite and regular.
And no major injuries, ideally.
Ideally, yes. But the update document adds a nuance. Even with injuries, if their airway is at risk, maybe from blood or vomit,
Getting them on their side might be better.
it might be the priority to keep that airway clear. It's a judgment call, but protecting the airway is paramount.
Okay, so how do we actually get someone into this position? It looks kind of complicated.
It's a sequence, but it flows. Kneel beside them, take the arm nearest you, put it out at a right angle, palm up.
Like they're waving.
Sort of, yeah. Then take their other arm, bring it across their chest, and place the back of their hand against their cheek nearest you. Hold it there.
Okay, hand against cheek.
Then, with your other hand, grab their far knee, bend it up so their foot is flat on the floor. Now you use that bent leg as a lever. Pull the knee towards you, rolling them onto their side.
Gently does it.
Gently but firmly. As they roll, their head is supported by the hand you placed on their cheek. Once they're on their side, adjust the top leg, the one you pulled over, so the hip and knee are bent at right angles, like they're running.
That stabilizes them.
Exactly. Stops them rolling back or too far forward. And the final crucial check. Make sure the head is tilted slightly back, ensuring the airway stays open. Check the mouth is clear.
Right. And once they're stable and breathing,
Don't just leave them. Keep checking that breathing constantly. Make sure it stays normal. If help is delayed, the handbook says to turn them onto the other side after 30 minutes.
and any special considerations?
Yes, very important. If the casualty is pregnant, always place them on their left side if possible.
Why the left?
Avoids the weight of the baby pressing on a major blood vessel, which can affect blood flow back to the heart. So, left side for pregnancy.
Good tip. Okay, recovery position covered. Next up, seizures.
Right. A seizure, as the handbook says, is like an electrical storm in the brain. A sudden burst of activity can look quite different depending on the type.
Partial versus generalized.
Yeah. Partial might just be a blank stare, maybe some twitching. Generalized is usually what people think of loss of consciousness, body stiffens, then jerking or convulsions. For EFLW, we mainly focus on managing the generalized type.
Okay, so if someone collapses and starts convulsing, what's our priority?
Safety. Protect them from injury during the seizure. Don't try to restrain their movements.
Don't hold them down.
No. Just try to clear space around them, move furniture, hard objects. If you can, gently cushion their head with something soft. A jacket, a cushion. Loosen tight clothing around the neck. Take off glasses.
And absolutely nothing in the mouth, right?
Absolutely nothing. Don't try to force anything between their teeth. That's an old myth and can cause serious injury. Just let the seizure run its course. Try and note the time it started.
When do we call 999?
Definitely call. If the seizure lasts more than 5 minutes, check your local guidelines, though. Or if they have another seizure straight after the first one without waking up in between. Or if they injure themselves badly, or if you know it's their very first seizure.
Okay. And after the shaking stops?
Once the seizure finishes, they might be sleepy, confused, maybe a bit groggy. Check their airway and breathing. If they're breathing normally but unresponsive, clear any saliva from their mouth gently and place them in the recovery position.
And just be reassuring.
Very much so. They might feel embarrassed or scared. Stay with them. Offer quiet reassurance until they've fully recovered or help arrives.
Okay, that's clear. Let's talk choking next. Airway obstruction.
Yeah, something gets stuck. Can be partial or complete, mild or severe.
How do we tell the difference? The update clarifies this, right?
It does. Mild choking. They can still cough, maybe speak a bit, Gasp for air. They're clearly struggling, but air is still moving.
So they can still make noise.
Usually, yes.
Okay.
Severe choking. They can't cough effectively, or maybe just a silent cough. They can't speak or breathe. They might clutch their throat, look panicked, go red in the face, then maybe blue or gray. This is urgent.
Okay, so what's the first aid? Let's start with an adult or older child.
Yeah.
Mild choking first.
If it's mild and they're coughing effectively, the best thing is encourage them. Keep coughing. Don't interfere yet. Just stay with them. The cough reflex is powerful.
But if the cough is weak or non-existent, or if it was severe from the start,
then you act fast. Lean them forward. Support their chest with one hand. Give up to 5 sharp back blows between the shoulder blades with the heel of your other hand.
5 sharp slaps.
Mm-hmm.
Check after each one.
Ideally, yeah. See if the object comes out, if 5 back blows don't work.
Abdominal thrusts. The Heimlich maneuver.
Exactly. Stand behind them. Wrap your arms around their upper abdomen. Make a fist with one hand. Place it thumb side in, just above their belly button but below the ribs.
Got it.
Grasp that fist with your other hand. Pull sharply inwards and upwards. A distinct J-shaped motion up to 5 times.
In and up. 5 times.
Yep. And you keep alternating. 5 back blows, then 5 abdominal thrusts. Check if it's cleared after each set. Keep going.
What if they become unresponsive during this?
If they lose consciousness, carefully lower them to the floor. Immediately start CPR, beginning with chest compressions, and make sure someone has called 999 or 112. Every time you open the airway for rescue breaths during CPR, quickly look in the mouth for the object. If you see it, try to sweep it out.
Okay, CPR if they go unconscious.
Yeah.
And even if the object comes out, they should probably get checked out.
Definitely, especially after abdominal thrusts, which can sometimes cause internal injury. Always advise medical assessment afterward.
What about infants? Briefly.
Different technique. For babies under 1, it's 5 back blows while they're face down along your forearm, head supported lower than their body. Then 5 chest thrusts, like CPR compressions, but sharper, in the center of the chest, face up. No abdominal thrusts for infants.
Good distinction, right? Nearly there. External bleeding.
Okay, blood on the outside. The handbook mentions different types based on the vessel.
Arterial, venous, capillary.
Yeah. Arterial, bright red, spurting, potentially very serious, fast blood loss. Venous, darker red, steady flow or gush. Also very serious. Capillary. Slow ooze, like from a graze. Usually less worrying.
But the basic treatment is similar for significant bleeding, right?
Pretty much. First step, gloves. Protect yourself.
Always gloves.
Then get the person to sit or lie down. Helps prevent fainting and slows bleeding a bit. Have a look at the wound, but don't start digging around in it or pulling out embedded objects.
That's the main thing. Pressure.
Direct pressure, firmly, right onto the bleeding point. Use a sterile dressing if you have one, or the cleanest thing available, a cloth. Even their own hand initially. Press hard.
Keep pressing. What if it soaks through?
Don't take the first pad off. Put a second one right on top. Keep pressing if that one soaks through quickly.
Then what?
The latest guidance suggests removing the soaked dressings and applying a fresh one, making sure you're pressing on exactly the right spot with even firmer pressure. Maybe you missed the main bleeding point initially. Elevate the limb if possible, unless it's broken.
Okay. And keep them calm. Treat for shock.
Definitely be ready to treat for shock. Keep them warm. No food or drink. Call 999-112 for any bleeding you can't control easily or if it looks serious. And keep monitoring them.
What about those embedded objects if something's stuck in the wound?
Yeah, key point. Leave it in. Pulling it out could make bleeding much worse. Instead, apply pressure around the object. Build up padding on either side to support it, then bandage over the padding and the object without pressing directly on the object itself.
Control the bleeding around it. Got it. Call 999.
Absolutely. That needs hospital treatment.
Okay, last topic. Hypovolemic shock. Sounds serious.
It is. Life-threatening. It's shock caused by losing a lot of body fluid, usually blood from severe bleeding, but could also be from severe vomiting, diarrhea, burns, anything causing major fluid loss.
The body can't cope with the loss.
Exactly. Not enough fluid volume circulating to keep the organs supplied with oxygenated blood.
What are the signs? How do we spot it?
Look for pale, cold, clammy skin. It might look grayish or even bluish, especially lips and nail beds. They'll likely have a weak but rapid pulse.
Breathing fast, too.
Rapid, shallow breathing, yeah. They might feel sick, anxious, confused, thirsty, or dizzy. Might even collapse.
So what do we do?
First, try to treat the cause if obvious, like controlling that severe bleeding we just talked about. Call 999-112 immediately. This is always an emergency.
Right.
Lay them down flat. If possible and no leg injury suspected, raise their legs. Prop their feet up on a bag or chair, maybe 12 inches or so. Helps blood flow back towards the vital organs.
Keep them warm.
Yes, loosen tight clothing at the neck, chest, waist. Cover them with a blanket or coats. Keep them warm, but don't overheat them.
Anything else? Food or drink?
No, nothing by mouth, even if they say they're thirsty. Just moisten their lips if needed. Keep monitoring their breathing, pulse, and level of response until help arrives.
Right. Treat the cause. Call 999, lay them down, raise legs, keep warm, nothing by mouth, monitor.
That's the gist of it. Simple steps, but they can make a huge difference.
Wow. Okay. We've really covered the key practical areas for that EFA assessment, haven't we? DR, ABCD, CPR, AED, recovery position, seizures, choking, bleeding, shock.
We have. It's been a pretty focused run through, hitting those essentials from the handbook and those 2022 updates. Hopefully it gives you a solid base.
Yeah, think of this as getting the theory straight in your head again. But remember, this audio guide is great for refreshing.
But it's no substitute for the hands-on practice. The course with Paul Kenny training, that's where you'll really build the skills, the muscle memory, and importantly, the confidence.
Definitely. So use this alongside your course materials. Go back over things, make sure it clicks.
Absolutely. And maybe leave you with this thought. Think about how in those first few critical moments, what you do, your actions, based on this knowledge. Well, it can genuinely change someone's entire outcome.
Your preparedness really is their hope. Something to keep in mind.